Hello, I'm Dr. Beth Karlan, and I chair the Ovarian Cancer Research Alliance's Scientific Advisory Committee. I'm honored to be here with you today to discuss what's new in ovarian cancer research and treatment. In my day job, I'm the professor and vice chair of Women's Health Research in the Department of Obstetrics and Gynecology at the David Geffen School of Medicine at UCLA, and the director of Cancer Population Genetics at UCLA's Johnson Comprehensive Cancer Center. But being here with you today has taken on a whole new meaning in this era of COVID-19 and the pandemic. I hope all of you have been able to stay well during these trying times, but I do want to give a shout out to OCRA for adapting this format to a virtual meeting so that we can bring you what's new and you can enjoy each other's company, even if it's just virtually. For today's talk, I think we should address some of the aspects of COVID and cancer, but really then just focus on this very exciting year in ovarian cancer research, where there have been many presentations at our national meetings, again, looking at the role of debulking surgery, the real breakthroughs in PARP inhibitor therapy. Should all ovarian cancer patients get a PARP inhibitor? Genetic testing and what's come forward with that. And yes, everyone should have genetic testing. And what's on the horizon for immunotherapy? Those are some of the topics we'll be getting into this morning. What you see here is the impact the pandemic has had on cancer patients and their doctor visits. What you see on the left side is a significant drop in the number of patients that have gone in to see their doctor for their regularly scheduled cancer follow-up, chemotherapy, and other visits. The blue is 2019, the red is 2020. From January before the pandemic to April, just in the early spring, there's a 50% reduction in the number of cancer patients who went in to see their doctors. In the right-hand panel are data showing the drop in patients who presented with new cancer diagnoses. Whether this was because they ignored symptoms, they were afraid to come in, but it's very concerning to see this significant 2/3 drop in the diagnoses of new cancers. These data led the National Cancer Institute to do some modeling of the potential effects the pandemic will have on cancer mortality. They used data from breast cancer and colorectal cancer because they are more common. But what we see here is that we expect to see excess deaths due to breast and colorectal cancer over the coming decade. The next few years, we'll see a significant increase. 3%, 2% may not seem a lot, but it is a lot in the numbers of patients who will die due to these cancers because of delays in either diagnoses or delays in their treatments. Dr. Sharpless, the director of the NCI, has estimated that COVID-19 is expected to increase mortality by at least 10,000 deaths due to breast and colorectal cancers over the next 10 years. Sobering numbers. But what can you do? We all know we need to take precautions, but we also need to know what we can support one another together. Dr. Fauci has given us 5 simple steps to help gain control of COVID-19 in the US in general. And I hope we all are aware of these, but universal mask wearing, social distancing and keeping at least 6 feet between people, good hand hygiene, frequent hand washing. When you do have activities, push them outdoors. Optimize ventilation when you're indoors, have fans, keep windows and doors open. Really avoid social gatherings, especially those that are conducted indoors with larger numbers of people. But stay in touch with your doctor. We can get through this together. Your physician and their office staff are there for you. Telehealth visits can really help stay connected. I've actually enjoyed having these, I call them virtual house calls, to have sort of a more homey, intimate setting, to talk about how you're doing, how you're living with your cancer, what are your concerns, often getting family members to weigh in as well. See your backyard, see your living room, and really connect over that. But express your fears, your anxieties, your questions. You're not alone. We're all having these concerns in the time of this pandemic, how we're going to live our lives, the things we're missing out on, and what does the future look like. Understand the precautions that are most appropriate to where you live. Each state has different number of cases, each county. I'm here in California, and it's really very different between the North and the South, and where you are around the world. Listen to your public health officials. Don't place yourself at any additional risk with unnecessary outings and social gatherings. If you have a family member or friend who can go to the market for you and do other errands, let them do it. It'll be their pleasure, really. When they bring the groceries over, they can leave them outside. You can socially distance and still stay safe. There will be a brighter future ahead. You can see your family and grandkids, friends, across the yard, from your porch, or through these virtual platforms. When possible, meet outdoors. The circulation really does help. But be assured, go to see your doctor. They are safe. The medical offices are taking extra precautions with health screenings before you visit, temperature checks when you get there, masks and face shields for all of us. We use social distancing in waiting rooms. We have extra staff on board to do extra cleaning, extra hand washing. Do go in and make sure we can take care of you. Wear a mask when you go out, and again, we can get through this together. So, why are we here today? The OCRA's national meeting brings us together to learn what's new, learn how others are coping, have support from one another, even virtual hugs if they need to be, to network, meet other women with ovarian cancer, other families, and learn from one another. And of course, remembering why we're going through all this. We treat you so you can live your best life. And I know we're all in this together. So many of you are living this trajectory. This is just an example of the course of a patient with advanced ovarian cancer. You have a diagnosis, there's surgery and chemotherapy, and you get to remission, and you're really enjoying life, and then the cancer comes back. Maybe 2 years, 3 years later, you have symptoms, you have a scan, and again, you're told you need to go back on treatment. You're in a platinum-sensitive situation, you get a platinum combination again, perhaps followed by a PARP inhibitor. Keeps you in remission again, but not as long as the first time. Maybe only half as long. You recur again, you get another line of chemo, get back to remission, celebrate, but it doesn't last as long again. The remissions keep getting shorter. There are additional treatments, there are additional clinical trials you may participate in. But as time goes on, 5th, 6th, 7th, 8th, 9th chemo, ultimately we have resistant ovarian cancer. There's frequently a bowel obstruction that leads to death. We know no one's going to live forever, but indeed this is the typical course. But the tides are changing. There is good news. Based on multiple clinical trials, new data coming out, women with ovarian cancer can expect to live longer and live better. We're continuing to push that survival curve rightward with all these new data. And that's really what I'm excited to share with you today. Surgery and debulking surgery has really been the cornerstone of treatment for advanced ovarian cancer. It was almost a religion I was brought up on as a gynecologic oncologist. Be in the operating room, comfortable shoes, 6, 7, 8 hours, remove all visible disease, whether that means a bowel resection, a liver resection, a diaphragm resection. Patients often staying in the ICU, but we really believed this was the key to improving survival for ovarian cancer. There were a number of trials that came out initially from Europe, but then repeated here in the US and really globally in Japan and elsewhere, demonstrating that debulking with chemotherapy, chemical debulking, and then doing surgery, again to no visible disease, had the same outcomes for both progression-free survival, PFS, and overall survival, OS, when compared to primary debulking surgery. It was hard to believe, which is why there was one trial after another. But I think we now understand that whether you have a combination of surgery first and then chemo, or chemo first and then surgery, the outcomes really are equivalent. But we've then took this to the next stage. If it works in the upfront setting, maybe there's a role for debulking surgery when the tumors recur. Again, now you may have more resistant clones. Chemotherapy may not be as good, and we need to get in there and remove that tumor. A lot of questions, once again. These are data that the Gynecologic Oncology Group did here in the United States, looking at women who recurred with platinum-sensitive ovarian cancer, and they were randomized to undergo debulking surgery versus, again, chemotherapy. And the women who had the surgery actually had no improvement in overall survival compared to the women who began with just the chemotherapy. There was a decrease in the quality of life, especially right after surgery for those that underwent the surgical arm, but really nothing that lasted very long. Well, this year at ASCO, this study was presented called Desktop 3 that came out of Europe, and we've been waiting for these results for a very long time. This was a large randomized trial again, looking at secondary cytoreduction, again, secondary debulking surgery for women who have recurrent ovarian cancer who've initially been in remission due to after their platinum chemotherapy. And the overall group, again, there was no difference between doing debulking surgery versus just resuming a platinum-based combination chemotherapy. However, this subgroup analysis really gave us some pause for thought and really think about how do we best select patients for the secondary debulking surgery. And what you see here on the left for overall survival is those that underwent surgery and had some residual tumor. Again, if you had some complete resection, you did better in the purple line. But if you didn't get all the tumor out, there really wasn't as much of a difference. So really, as a clinician, as a gynecologic oncologist, being able to select those patients who we believe we could get out all the tumor, really we could afford them a significantly improved survival. So like with primary debulking surgery, secondary debulking surgery can significantly benefit selected patients. Who are those women? Women who've had at least a year since they completed their chemotherapy, women who on their scans have only a few sites of disease, under 3 sites, and understand that this is what they want to do. They're up for it. They're up for the aggressive approach. Like with primary debulking surgery, you need to get out all the tumor. And so patient selection is key, but also the team that you have with your physician, with your doctors, gynecologic oncologist, and surgeon is also key. When you can achieve no visible disease, the overall survival is more than 5 years compared to under 4 years with no surgery and doing just the chemotherapy. So surgical skill, how long you've been in remission, how many tumor sites you see on your scan, and really the shared decision-making will help you live longer and live better. One other thing that wasn't presented at the meetings but did come out last month and I want to bring up to you, and it's the idea of intraperitoneal treatments once again. And this is the idea of adding heated chemotherapy at the end of your debulking surgery. So if you can get out all the tumor before the abdomen is closed and you're off the operating room table, you get a treatment with hot chemotherapy. And what we're learning about more and more is that the microenvironment where the tumor cells live can really be influenced and really prime it to not be able to come back. And that's what's being done here. And this trial that was published, again, just last month, showed that if you use the heated chemotherapy after getting out all the tumor that you saw versus just going on to get your regular chemotherapy afterwards, The likelihood that you would survive another 5 years was about 50% versus less than 30% if you didn't get the heated chemo. Again, not for everyone, but this is not considered experimental anymore and is indeed placed in the National Comprehensive Cancer Network's recommendations as an option for recurrent ovarian cancer. So another option to discuss. But I'm going to move away from surgery for a moment and go to the excitement that's come in systemic treatments and focus on some of the targeted treatments, PARP inhibitors, and immunotherapy. So our first-line standard of care for ovarian cancer for about 30 years now has been a platinum-based combination chemotherapy with a platinum and a taxane, typically carboplatin and Taxol. And what this summary slide shows you is that for a long time we looked at, should we give the platinum and Taxol every 3 weeks? Should we give dose-dense Taxol and do the Taxol every week? Or should we give both the carbo and the Taxol a lower dose every week together? And really, it didn't matter. And I think what's right for you is what's right for you. Where do you live? In this time of COVID, you may want to avoid weekly visits to the doctor to be getting the infusions. Decide with your physician which type of combination is going to be best for you. But really, I'll reassure you that survival with the combination of the carboplatin and the Taxol, they're all about the same. Maintenance therapy, meaning a treatment, some type of treatment after you complete your chemotherapy to allow you to live longer, has been studied for many, many years in ovarian cancer. There have been many other treatments tried. More recently, we've had some insights to some maintenance therapies that seem to work, at least to deliver longer times in remission, better progression-free survival. And what you see here are two large studies, the GOG study done here in the US and the ICON study done in Europe, demonstrating that adding the targeted agent bevacizumab, or Avastin, which targets the vascular growth factors within the tumor, can improve the progression-free survival for a number of months to keep you in remission longer. In the GOG study, it was about 4 months, and the ICON study a little under 2 months. But again, taking the bevacizumab after you've completed your chemo can keep you in remission longer with a good quality of life. Well, I think these data really rocked our world in the ovarian cancer community in a very positive way for patients, families, and physicians. Here we see the results from the SOLO-1 trial showing how the PARP inhibitor olaparib significantly improved the progression-free survival for women who had ovarian cancer and had an inherited mutation in the BRCA gene. Look at the separation of those curves. Here you see 60% of those women who were randomized to get olaparib in maintenance after they completed their chemotherapy was still without evidence of disease at 3 years, versus less than a third of those women who went into the placebo arm. Indeed, one way mathematically to discuss this is with a hazard ratio. So there was a 70% chance that you would have, greater chance that you would have progression if you were not taking a PARP inhibitor. And what we see is that that PARP inhibitor curve really flattens out. And maybe some of those women who are still without any disease at 5 years, who knows, maybe it'll go on like that for 10 years, or maybe they'll be cured. So I think we're still waiting for the overall survival from this, but this, I think, really shook our world. So why do PARP inhibitors work? How do they work? And can they be applied to others? So our DNA in our cells is essential to how we live every single day. And over evolution, there are multiple repair pathways that have evolved to ensure DNA integrity. Meaning that, you could be outside, it could be ultraviolet light. I hope you're not a smoker, but it could be smoke, it could be something you eat, and you get a break in your DNA. And that happens all the time. So we need multiple pathways to keep our DNA intact. Almost all the inherited cancer genes, BRCA, Lynch syndrome genes, etc., impair DNA repair. BRCA genes, though, when they have a mutation, they impair one of these repair mechanisms called homologous recombination. And it was really brilliant that we came up with this idea, the investigators in England actually, and some of us here in the US, looking at ways to exploit the DNA vulnerability brought out by PARP inhibitors, what we now call synthetic lethality. So PARP, polyadenosine ribose polymerase, helps to repair genes when there's a single-stranded break, when there's just a little crack in one of the strands of the DNA. And a PARP inhibitor impairs that ability to repair that single-stranded break, so that when the cells go to reproduce, they get a double-stranded break. To repair a double-stranded break with the right base pairing, you need to use homologous recombination, which is knocked out with a BRCA mutation. Since you can't use that pathway, there's still another pathway, non-homologous end joining, for example. And while that can repair DNA, it doesn't always pair up the right base pairs, so that the cells have kinks and loops, and the cell ultimately dies. But what we've learned is that DNA repair deficiency is actually present in a large number of ovarian cancer cells. It's not just those that inherit a BRCA gene. You can acquire a BRCA mutation as part of your cancer. You can have the promoter, which turns on the BRCA gene, be in the permanent off position, something we call methylation. Then there are other genes that are involved in homologous recombination repair, part of the Fanconi syndrome, Fanconi anemia genes, such as RAD51C, RAD51D, BRIP, etc. There are other genes like PTEN involved with Cowden syndrome, things from the Lynch syndrome genes, the MMR genes. All those perhaps can be helped with the PARP inhibitor, and those are trials that are ongoing, and some of the early data show indeed PARP inhibitors can help in many of those situations. There's still another group of cells, so we still have a lot of work to do. Those tumors that have alterations and things like cyclin E1 don't seem to be at all susceptible to PARP inhibition. So knowing your genetics is vitally important, and I hope that everyone here has already had germline genetic testing, because having a mutation, inheriting a mutation in one of these DNA repair genes is found in almost 20% of all ovarian cancer patients. It's not just those with the family history. We have smaller families, and ovarian cancer is not that common. So of those women who have a mutation, about 40% of them have no family history of cancer. And in fact, the current guidelines, both from the NCCN and ASCO, say that all women who have invasive ovarian cancer should be offered genetic testing. You can meet with a counselor, meet with your physician, decide if it's right for you, but I do think it's vitally important because of the data we just showed you, your likelihood of benefiting from a PARP inhibitor can really be underlined. It's important to begin with the germline, the blood or saliva testing versus just testing your tumor, in my opinion. While tumor testing can be helpful, some of the times you will miss having a BRCA mutation in your blood if you test only the tumor. And the real benefit of also doing the germline testing is you can then cascade that information to your family members so that perhaps they can find out too that they have one of these inherited mutations and take steps to prevent getting cancer completely. ASCO, as I mentioned, also recommends all ovarian cancer patients, irrespective of family history, should have testing, should have genetic testing. If your tumor testing, if the germline testing is negative, however, then you really should do the somatic testing. Find out if your tumor has one of these other types of changes, often called homologous recombination deficiency, HRD, so that, see again, will PARP inhibitors benefit you? If the type of ovarian cancer you have, clear cell, endometrioid, often those tumors will have other types, these MMR genes that may be altered, and those are very susceptible to immunotherapy, something that can really help you. So do the testing, meet with your genetic counselor, do the germline testing, and in many cases also do the tumor testing to decide what types of targeted therapy can really offer you some benefit of longer survival. And just to show you how this really goes across multiple trials and multiple agents, here are 3 trials. PARP inhibitors have been transformative, especially if you have a BRCA mutation. So we have data from SOLO using olaparib, data from Prima, again using niraparib, and Paola, again, used olaparib, but these patients also had used bevacizumab. So if you have a BRCA mutation, after you complete your platinum-based chemotherapy, going on a PARP inhibitor can help you live longer. If you've been in remission and then you recur, again, PARP inhibitors very similarly. Curves look very much the same. All three different PARP inhibitors, olaparib in Solo, niraparib in Nova, and rucaparib in Ariel. Again, the curves have about the same separation, survival benefits about the same, and these hazard ratios of under 3, really, I don't recall ever seeing before. PARP inhibitors really have transformed the way we treat these patients who have tumors or inherited mutations in the BRCA or the Fanconi pathway. And something I think we in the ovarian cancer community feel proud of, this really was piloted in the ovarian cancer patients, but these data have been so strong that they've been applied to breast cancer, pancreatic cancer, and prostate cancer, all of who now have approvals for the use of PARP inhibitors when there is a BRCA mutation in any one of those tumors as well. Really discoveries that grew out of our experience in ovarian cancer. Unfortunately, we still have work to do. Certain groups benefit less from the use of PARP inhibitors. If your tumor is discovered if you haven't inherited a BRCA mutation and you are HRD negative, again, there's no mutation in your tumor tissue itself, the benefit from PARP inhibitors is not as great. We see a little bit in Prima that the HRD negative, this high-risk group, did have some benefit from niraparib, but the other trials really didn't show much benefit at all. And similarly, if you don't have a BRCA mutation in your tumor or inherited, we don't see much benefit in the recurrent setting. Again, there is a bit of benefit, and if you have platinum-sensitive disease still, and you've had a longer disease-free interval, it is still worth trying a PARP inhibitor. I think that really can give you some benefit, but we still need to look for something that is even better than that. And those trials are really ongoing, and we're trying to say, what's next? Okay, we said frontline maintenance. Perhaps if you don't have one of these genetic alterations, maintenance with Avastin, with bevacizumab may work, as I showed you in the first slide when we began discussing this. In the recurrent setting, very similarly, PARP inhibitors after chemotherapy if you have an alteration, maybe for everybody if you have platinum-sensitive disease, or perhaps maintenance, again, with bevacizumab. But there's other situations. How else can we use a PARP inhibitor? Can we actually avoid chemotherapy? How can we gain benefit from this approach of synthetic lethality by combining a PARP inhibitor with another drug? If you were responding to a PARP one time, can you respond again? And where is immunotherapy fit in all this? So these data were presented at ASCO this year. Again, very exciting. Phase 3 randomized trial in patients who had recurrent platinum-sensitive disease to get only a PARP inhibitor to treat their tumor or chemotherapy. And what we see here is that the PARP inhibitor olaparib did at least as well, actually did better, statistically better than chemotherapy in patients who had platinum-sensitive recurrent disease. So you can discuss with your physician, what are your side effects? How is your bone marrow? And does it pay for you to perhaps take only a PARP inhibitor instead of chemotherapy again? And again, here are the survival curves, at least for progression-free survival. Taking the PARP inhibitor seemed to provide better progression-free survival than the chemotherapy. It would be nice to think that we could begin to move away from chemotherapy and go to a targeted treatment like this for patients who have recurrent ovarian cancer. Again, I should point out that these in Solo 3, once again, it was only patients who had a BRCA mutation. And I'm not forgetting the majority of ovarian cancer patients do not have a BRCA mutation. And I think that's where a lot of the work is right now to look at better combinations. This was one trial, again, using olaparib with a targeted agent, cediranib, that is similar to a bevacizumab, but it attacks other targets as well, but looks at ways to prevent the growth of the blood vessels into the tumor and sort of choking off their food supply that way. So here patients were randomized to get PARP inhibitor plus the cediranib or chemo. And in those patients who had BRCA mutations or tumor mutations, when they combined the combinations, it appeared that the combination with the olaparib did better than chemo or PARP alone. However, when you had patients who did not have tumor mutations, there really wasn't a significant difference, and we need to continue to work harder in this area. So it brings us to immunotherapy. I perhaps alluded to it for a moment when I mentioned the heated chemotherapy, that the microenvironment where the tumor cells live is just as important to the growth and behavior of the tumor as are the cells themselves. Think about your garden outside, and the cancer are weeds. And if you take those weeds and you have them now growing in your beautiful garden and you don't want them there, put those weeds in sand and they'll die. And those are ways we can alter the microenvironment. So this was a paper almost 20 years ago in 2003, looking at tumor infiltrating lymphocytes, TIL. So these are immune cells. And what we see is that they can live and infiltrate in the tumors. And we see TILs present in about half of ovarian cancers and absent in the other half. And what these early data showed in different studies is that when you had a lot of the immune cells in the tumor, again, retrospective data, you did have a better survival. So with the advent of all these new immunotherapies, there was a lot of excitement for possible use in the ovarian cancer patients. The approach that's been used most recently is something called checkpoint blockade, a way to stop the receptors, to block the receptors on the cells that allow the immune cells to attack the cancer. And these are multiple agents. Some were checkpoint inhibitors, some inhibited other aspects of this pathway, and used in recurrent ovarian cancer, relatively small studies. These were the pilot studies. But one after another, when you look at the results, the response rates are 10%, 10, maybe 20% stable disease a little bit, but really very disappointing. And so I think we said, how do we activate the immune system to fight ovarian cancer? We know the cells are there, but how do we turn them on again and charge them to go after the ovarian cancer cells themselves? We've often in the immunology talked about hot tumors and cold tumors, and a hot tumor is immunogenic, where you have the cells there and they all come in and really can fight the cancer. But what seems to have happened in ovarian cancer, these cells are exhausted. They're there and there's too many suppressors around made by the ovarian cancers that block the cells. So the ovarian cancers have this cloaking mechanism that won't let the T cells attack the cancer cells and kill them. So we've been thinking about how do we get around this? This study was also presented at ASCO this year, using a checkpoint inhibitor, but in different times in ovarian cancer and in different doses and all. The first cohort had women who had recurrent ovarian cancer who had between 1 and 3 previous treatments, and the second cohort were those patients who've had between 4 and 6 prior treatments. And they were treated with the checkpoint inhibitor pembrolizumab every 3 weeks. And while the overall response seen in these different groups was still only around 10%, I think when you look at the best overall response, complete response, partial response, and stable disease, it's almost half of the patients Even those women who've had very much pre-treated cancer, have had 6 prior treatments, they're able to get to stable disease with a treatment that does not have a lot of toxicity, that now can be used once every 6 weeks as an infusion even. And I think even more exciting was that the duration of that response was, in some cases, more than 2 years. So you've had 6 prior treatments. This treatment is well tolerated, can be infused once every 6 weeks, and perhaps can give you a significantly longer survival. So I think a lot of us are working to how can we turn these cold tumors into hot tumors? And here was one idea. Can we use a PARP inhibitor to make some damage in the DNA within the cell, combined with a checkpoint inhibitor? So here's pembrolizumab and niraparib, a checkpoint inhibitor and a PARP inhibitor, and one with recurrent platinum-resistant ovarian cancer. Some of us, the most difficult situations. So this is what we call a waterfall plot on the left. And you see patients, even whether or not they had a mutation in their BRCA or inherited mutation, okay, whether or not, so it's the blue ones that have the mutation, but you see a lot of the lighter color ones still are seeing a response. Their tumors are getting smaller in that right side of that curve. And the duration of response similarly was long. So it appeared that this combination, which was very well tolerated, had higher than expected responses in those patients who had wild type, had normal genetics in their cells, and still have platinum-resistant ovarian cancer. So something that I think can help improve the outcome for these women. Another idea is combine different types of checkpoint inhibitors. Let's, just like we talked earlier about DNA repair mechanisms, the immune system is even more fully evolved, and there's multiple checkpoint inhibitors. So here we combine 2 different types of blockade using 2 immunotherapy agents, nivolumab and ipilimumab, for recurrent ovarian cancer. And this was a GOG-NRG study. And what we saw was, and again, it was a phase 2 study, so it's relatively small, but this combination of Nivo and Ipi, as we call them, had a response rate of about 31% with statistical significance. But the clear cell patients who have clear cell ovarian cancer, have been notoriously resistant to platinum agents, and really a challenge for all of us to keep in remission. And it appeared to really have the most significant benefit in patients with clear cell tumors, and should be something that should be considered in those women to provide them a longer survival. There have been multiple trials that have been ongoing for the last number of years, applying immunotherapy approaches to ovarian cancer. I have to say it's still a work in progress, and really very hard work being done by many centers around the country. These were 3 large trials looking at chemo combinations with checkpoint inhibitors, different chemotherapies, platinum-resistant disease, upfront disease, and unfortunately, they did not reach their survival endpoints to really demonstrate a significance in progression-free survival. But there are many other approaches that are already underway. I showed you combining immunotherapies with the PARP inhibitors. We combine immunotherapy with bevacizumab or cediranib, again, targeted agents that attack the blood vessels. We combine immunotherapies with PARP inhibitors, as I said. Here's another trial, durvalumab and olaparib. I showed you the pembro and niraparib trial. Other targeted agents. Many of you may have heard of mirvetuximab, which targets the folate receptor. That's also being combined with immunotherapy. Sometimes radiation has been used, since the type of killing that radiation does, causing double-stranded breaks, seems to activate the immune system. And even if you radiate one area of the tumor, it turns on the immune system elsewhere, something we call the anescopal effect, where you see an effect of tumor shrinkage distant from the radiation field, and that's also being studied. There are multiple vaccine trials underway, CAR T-cell therapy trials underway, and I think stay tuned. I am very enthusiastic, very optimistic that immune therapies will offer benefit to ovarian cancer patients. We just have a bit more work to do. I think to get to these answers, we need to have clinical trials. We need to have data that can allow us to provide this closely watched group of patients to have an impact around the world. These are just some of the clinical trial sites that you all probably know already, that you can check out to see, is there a trial for you? Is there a trial near you? Discuss this with your physician. You're not being guinea pigs. You really are helping, hopefully, yourself and also those other women and perhaps family members who may be in a similar situation. OCRA is here for you. Your physician and healthcare team are here for you. Cancers are still cancers during a pandemic. We will get through this time together and hopefully continuing to make discoveries that will allow you to live longer and live better. Thank you for your time this morning. I hope to see you next year at the Ovarian Cancer National Alliance's annual meeting. Take care of yourself, stay healthy, and we're here for you.